Implants. Here we are back on implants. What are the advantages? Then we'll get to how it works and all that. The advantage of a single tooth replacement is, number one, there's no preparation of the adjacent teeth, right? I mean, just you leave those alone. There's absolutely no reason to touch the adjacent teeth at all. There is no decay possible on an implant. It's made of metal. Nothing will decay there. You can get some other problems, but we'll talk about them. There is zero risk of needing a root canal in that tooth because it's not a tooth, it's a titanium implant. It's improved hygiene because if you have, let's say, a 3-unit bridge, it's tough to clean under there. We make tools for it, but it's difficult. If you're wearing a partial denture and you have a snack, that food stays locked under your partial until you take it out and clean it. So much improved oral hygiene. It's just like having a regular tooth in there, except one that can't decay out. It improves the bone support. It actually stops all the bone loss of the alveolar bony process. I told you earlier that you go through atrophy of the bone, same as atrophy of the muscle, when there's no tooth there. But if there's an implant there, then the atrophy stops as well. So you maintain the facial support, all the business that goes with that. And there's a decreased risk of the adjacent tooth loss. One of the reasons that there's the domino effect of, back in the early slides, of the, 25 or 38% of teeth are lost within a certain number of years next to an adjacent tooth. Number 2 cause of tooth loss is a missing tooth. One of the reasons is because you're taking more of the load. If you're generating, say, 200 psi on an average bite, and you've got 4 chewing teeth over here, 2 molars and 2 premolars, assuming your wisdom tooth is gone, well, that's spread out 25% of that force amongst each tooth, unless you're pinpointing, say, a nut or something on one tooth. But once you miss a tooth or 2, you're supporting more of that bite on a smaller surface area because you have fewer teeth. And that's how we start to break and lose more teeth. So again, advantage here is decreased risk of the adjacent tooth being lost because everything's working in harmony. Also, in my mind, there's a cost savings to an implant. It's a little more than doing a bridge, but you're only going to do the implant once. A bridge you might likely do twice or longer, or more often if you have either some bad luck or bad dentistry, or just if you had the bridge early on in life. I know kids that lost teeth when they were in sports in high school. And they say adults now, and they're on their 2nd or 3rd bridge because it was lost. More advantages. If you are, that was single tooth replacement, all the advantages. If we are going to do a full arch replacement with implants, there are some advantages as well over a denture. Number 1, you're preserving bone. Again, you're not shrinking things away. You have facial support of the implants. Instead of caving in like Grandpa Jones, your face is supported. You're correcting the bite, so you have the correct bite and biting force. Again, when you're wearing dentures, you're diminished to less than 50 psi on your biting force, and things don't always line up well because you might be forced to make a denture that rides over whatever bone is left. It has to be centered up on what bone is left, and that's not necessarily where you want your bite to be if it's, say, opposing some natural teeth on the other arch. It's a real big discipline there to work with. Much greater increased functionality and stability. Again, it just acts like teeth. So when you don't have a blob of plastic in your mouth to chew through, you tend to just eat food like normal. And they can stay in. I say can because not all fully implant restored arches have teeth that stay in. There's some reasons, and there's some good reasons, but some do. I'll address all of it. And of course, to improve phonetics. If you're trying to speak through a piece of plastic that flaps around in your mouth, you tend to have problems pronouncing your words correctly. And then the social and psychological advantage of not having teeth to come out. If your teeth live in a glass jar at night, let's face it, that's not real sexy. If removable prosthetics are over implants, so I went back earlier, we have an RPD earlier, removable partial denture. If it's over your gums and a few teeth, meh. If it's over a bunch of implants, it comes out and in over the implants, fantastic. You'd be surprised at how well that works. I've got examples and models of them up here, and of course I'll show you that and talk about it here. The disadvantages of implants, it's the initial expense. They're not cheap. A single tooth can be $6,000 or more if you need some bone grafting. That's not the high number, that's not the low number. That's about middle. Anybody who's had one recently, you can attest that's about where you were. Bone grafting, I'll address more in a minute. A full arch can range from about $20,000 on the inexpensive end to as much as $35,000. I see you shaking your head. I know. Sorry. You wouldn't believe what my end of that is in terms of what we pay the lab and all that. Not to mention the training. Patient came up and asked me, how many implants do you do in a typical year? About 200 at this point for me. I've done about 2,000 implants over the years. I got trained 20 years ago, and a few in the beginning and more now, so my numbers are increasing. The cost of that education 20 years ago was more to me than 2 years of dental school. That doesn't come cheap. Implants aren't cheap. The training's not cheap. There's nothing inexpensive about it. And it's not like your computer where the cost keeps going down as the technology goes up. Medicine and dentistry just doesn't work that way. So it's a lot. What I do tell people is think of it as a car. If you're going to spend, let's say, $60,000 or $70,000 on your mouth, drive the same car for another 5 years. You might be driving a $60,000 car. I don't get into people's pocketbooks. I present them with opportunities to improve their dentistry and let them work it out. And if it works out, great. And if not, I have other options. But they all carry a level of compromise, which is what I went over before the break. All of those are compromises. Do people have those in their mouth and function with them? Yep. And they are compromised. Here's the uncompromised view. There is a 4% failure rate nationally, that's within the US, I don't know what it is globally, of dental implants. Most of those failures happen early in the process, during the healing phase, during the bone healing phase. You put an implant in, you wait several months for the bone to fuse to it. More on that in a minute. And usually the dentist will replace that for no charge. It's a pretty low incident. We replace ours at no charge if one fails. My current failure rate is 3%, not because I'm great. I think I just pick, I pick cases I'm really pretty snobby about what I'm going to do with somebody. And in particular, like my 108 or what it was, 208 time back from lunch, I'm particular about a lot of things. A particular dentist makes for good results. Not all dentists, this came up at the break too, not all dentists are adept at the work involved, but they do it anyway. And that's a significant disadvantage. Something you have to know about dental school and dentists. When we graduate, we are entitled to, by our license, do anything in the mouth that is out there. Orthodontics, periodontics, oral surgery, take out wisdom teeth, implants, fillings, crowns, bridges, dentures, all of it, we are licensed for that. There is absolutely no governing board. The Board of Dentistry doesn't say anything about what we choose to do. We are expected as professionals and as doctors to only do what is within our wheelhouse. And frankly, when we graduate from dental school, what's really in our wheelhouse strong is fillings, crowns, and root canals. And some places, not the root canals either. So it's up to us to get an awful lot more CE, continuing education, to get adept at this. But there is no requirement. And that is why there are some bad examples of dentistry out there, because a lot of people see dollar signs in their own head. They go, oh, I'm going to start doing implants. I took a weekend course. I'm good to go. No, you took a weekend course, so you're a little more dangerous now because you have more knowledge. It is a process. You've got to get there. So that is one of the disadvantages. You better know the dentist putting the stuff in your mouth. What about bone grafting? I mentioned that a minute ago. And I'm going to talk about healing as well, because I don't have any place else in my slides. In the typical disuse atrophy scenario of the alveolar bone that used to look like this with a tooth coming out of it, looks like this. It doesn't just all collapse straight on down. You'll lose some height, like we talked earlier, but the thickness is the big thing. That's really the biggest thing of all. And oftentimes when a tooth comes out of this, it takes some bone with it. Sometimes due to what we're doing. When I grab hold of a tooth and pull it out, sometimes the bone stays with the tooth. It's just tightly connected. So when that happens, we have a defect here. This is an example of one style of bone graft. We would take and flap the gums away from that, like taking a banana peel off a banana, where there's half of the banana missing up top. Graft in some particulate bone. I'm not going to get into the different types, but suffice it to say most of us use human bone, sometimes your bone, sometimes a cadaver. Drape it with a membrane. That little white sheet that's just under the red is a biologic membrane. Sometimes they're meant to dissolve, sometimes they're meant for us to take out. Again, depends on the situation. Gums are put back and allowed to heal. The bone grafts in, and then we go back and place an implant in a fully expanded ridge. That costs more. So when I said, $25,000 to $35,000 or more, here's your or more. When a tooth first comes out, especially say a molar, we're really concerned about the defect that's going to happen here. So this is a very common procedure known as a socket preservation graft. Take the tooth out, there's a socket left over. In other words, just a big hole where that tooth used to be. And if we do nothing and don't place the implant that day, and there are sometimes we can place it that day and sometimes we cannot. When we can place it that day is if there's no infection present, so you've been on some antibiotics usually, and the bone is sufficient down at the base to give me what's called primary stability. That is, if I put it in, is it going to fall over? Kind of put a little bit of pressure on it. How much pressure? About 10 newtons per centimeter. That converts to PSI. I don't know what the conversion is. It's a metric. So as long as I can torque it down to 10 newton centimeters, I've got primary stability. I can put it in. If those two things don't exist, I've got to wait. If I wait and leave the hole open, that hole is going to collapse, and I'll have to rebuild it. Rather than rebuilding it, how about we preserve what's there? So then we put in some particulate bone graft. Again, it might be from you. We've got ways to get that from the jawbone nearby, or it may more likely be cadaver bone. We also, over the years, have used both porcine and bovine, that is pig and cow. They also work, but the farther away we get from you, the worse it is. So your host bone is the best. Another person, human, is pretty good. And then other animals still work, not always quite as good. Higher failure rate. After that particulate bone is put in, we drape that with a membrane, again like the one that's up there. It's draped over. Again, some membranes are meant to sit and dissolve in. Other membranes are meant to be removed after a few weeks. Surgeon's choice, depends on the situation. Stitch it closed and wait. And then that will look like this when it heals instead of having to be rebuilt later on. It'll maintain its thickness. So if you can't put the implant in the same day, then we wait, but we graft the bones so it's still good and stable. And then a few months later, 4 to 6 in general, we go back and put the implant in and wait again. What are we waiting for? There's an awful lot of talk when you go to your dentist about the healing time. Well, you're not in pain for 4 to 6 months. We're just waiting for things to mature. That kind of healing. The surface of these implants used to be just pure polished titanium. But under a microscope, it's not so polished looking. Under a strong enough microscope, has anybody ever owned a boat they kept in salt water or seen one? You get barnacles on the bottom, very common. How in the world do those living organisms attach so rigidly? If you ever try to scrape them off, forget it, give it to the boatyard, it's tough to do. If you ever try to scrape them off, they're in there, they're built on. How does that living microorganism in the ocean attach itself to that shiny, smooth boat bottom? Because under a microscope, that shiny, smooth boat bottom is not so shiny smooth. It is like a surface of a sponge, like a kitchen sponge, millions of tiny pores. Same thing here. Even on a shiny implant that were polished, we just call it polished, there were still microporosities within it that the bone cells could grow into. Well, they improved that by actually creating not such a shiny surface. So we went from 6 months or more to more like 4 to 6 months now with abraded or etched surfaces. This, to the naked eye, looks rough. Under a microscope, it looks like caverns going through there. So your bone building cells, osteoblasts, are the ones that grow through there. Had a question earlier about osteoporosis or whatnot. What was the drug? Is it Beniva? That's one of the drugs, Beniva. Osteoporosis drugs, all the bisphosphonates. I can't remember them all now. Mostly, what is it? Fosamax, thank you. Fosamax is the leader of the pack. You know, most doctors aren't prescribing those anymore. And I'm not here giving medical advice, but if you're on one, talk to your doctor. If he still wants you on one, maybe talk to another doctor. They're not prescribing anymore. There's so many complications, one of which is dental. If you are on a bisphosphonate drug and we go to put any kind of a surgical device, do any kind of surgery, take a tooth out, put an implant in, expose the bone, do some gum surgery, the bone in there goes through what's called osteonecrosis. It just dies. Literally dies off in a zone. You can't stop it, so you go in and scrape that out. But now what have you done? You've disturbed the good bone next to it, and that goes through osteonecrosis. So you scrape that out. People lose a whole half a jaw going through this. There are some solutions to fix it, but you got to be in the right hands. It's usually involving some hospital work. If you've been off the Beniva or the Fosamax for 6 months, we're usually okay. But there's a titer that I can do. I can send you to the hospital for a blood test, and they can titer out a particular protein that tells me where you are in the process of being able to go. If it's been more than a year, no more reason to do the titer. We just go and we have good success. And again, most people are getting off the bisphosphonate drugs. If you have breast cancer, you may very likely have gotten bisphosphonates in your chemo cocktail. They don't tell you everything that's in your chemo, but a very popular one was a bisphosphonate injectable drug, FYI. So, under the surface, that is, again, a great big sponge, and the bone wants to grow into it. But we do have to wait for that to happen. And that's the waiting phase. Because again, we put an awful lot of pounds per square inch on that implant once we put a tooth on it, and we can't do that while it's still healing, or you'll break the connections of that immature bone that's trying to grow to the implant, and then you get a wobbly, loose goose implant. That's one of the reasons for a failure. Sinus lifting. So here's more bone grafting. If you have a bunch of back teeth taken out, ignore this side for a minute, please. If you have a bunch of teeth taken out in the back, an odd thing happens. The bone doesn't just atrophy from the tooth side upward. The sinus actually expands downward, eliminating some bone as it goes. And it literally ends up looking like this on an x-ray. Now, where the heck are you going to stick an implant in there? Tough to do. They used to do something called an onlay implant, which is where they would flap your gums in the back, all the way out of the way, take an impression of that, send it off to a lab, close you back together. The laboratory would take the impression of your bone and fabricate cast by themselves an implant, one post sticking out, that had what looked like a spider web coming off of it. Then the surgeon would open you back up and fix that spider web up into that thin bone, tack it in a couple of spots with screws that stayed forever, and then close you back up. As you can understand, that's a pretty horrific procedure to sit through. It's a lot of flapping and whatnot. So people don't do this anymore that I'm aware of, maybe other countries, but you don't see them. I don't even know of anybody that makes them anymore laboratory-wise. But it was popular for 10, 15 years. So what do? A sinus lift. Follow the bouncing ball here. If this is a cutout of that right there, so a sideward profile of that or a cross-section of it, we make a window up in the side of your cheek. That window I like to liken to my grandfather's garage door. My garage door is in 5 sections. It goes chuk, 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 chuk. My grandfather's garage door was one big piece of wood and it went voop up inside, right? Same thing here. We nick 3 sides of that bone and push it so that it folds up inside, creating a new roof, if you will, in there. That roof of bone is sitting up in here. I have special tools that go up in there and move the membrane up inside. There's a membrane inside or on all of your bones, and that's on from that side, like the membrane of an egg. Everybody here's cracked a raw egg in their life. You know when you crack it just a little bit, all those little pieces are still held together by the membrane that's in there. All right. Guess how we learned to do this in my training? Raw eggs. A lot of raw eggs. We had to drill a hole in the eggshell, 3 sides, move it up, and use the same tools we used for the sinus on the egg and manipulate that membrane without cracking it, without spilling egg all over the place. It was a bloody disaster. But we all got there. I mean, that was the secret, was you got there. And the egg is way more delicate in terms of its membrane than this is. So if you can do an egg, anybody can do this. Not to say it's easy, but it's doable. So then you lift that membrane up out of the way, inject some bony particles, same description as before, some human, some not. And in this case, we actually use a mix. There's been a lot of research in what's the best, because I need some human bone in there, I really do, to make that work, but I need some non-human bone to make it sit around longer or take up space while the human bone turns into your bone. Anyway, there's a recipe for that. Let that sit, now it's full, close the gums, let it heal over, you come back, you've got this set up, and now you have room for an implant. So you go from that defect to that full on. That's called a sinus lift. That may sound horrific as well, but it's not. I've done a bunch, people heal. Yes? It comes from a tissue bank. From you? A couple of different ways. If I need a lot of it, let's say a block of bone, if I'm going to rebuild, good example, I had a patient, he got kicked in the face when he was a teenager, went without his teeth up here for a long time. He finally made something of himself, had the money, let's go do it, right? Huge deficiency in bone. For him, I ungloved his mandible, meaning I just pulled everything down off the mandible, and I took a chunk of bone out of his mandible. That'll grow back in about 9 months. I could take it again in 9 months. It grows completely back. But I take that chunk and I place it up here. That's the short version of how it goes. More typically, I need granular bone. So I can take if there's extra bone laying around when I take a tooth out, so sometimes that happens. I take a tooth out, I want to put my implant in at a certain level, maybe a little deeper than the original tooth was, so there's some bone hanging up on the sides. I'll clip that off with something that looks like toenail clippers, more or less. Clip all that off and then morselize it. I've got 3 different tools in my office I can use to literally turn that little block of bone into granules. So that's one way. I've got another one that scrapes. It looks kind of like a little tiny cheese grater with just one scooper on it instead of 50 of them on the side of that thing. And it's got a receptacle on the back side. And if I just lift the gums out of the way nearby, I can scrape the outside of the jawbone right there and collect about a thimbleful from any one spot of granules. So there are ways to get it. Generally, we don't try to go to a second surgical site. If I've got you numb and doing surgery here, I try to find some bone there to get it. Another great place is if you have your wisdom teeth taken out, that all filled in with bone back there. I've got a whole tooth's worth, again, a thimbleful of tooth just waiting for me to harvest. So there's easy ways to do it. And some people are very objectionable to cadaver bone. It's safe, it's been used for years. It comes from a tissue bank, there's no diseases. At that point, it's really just like a calcium scaffolding. I mean, they've taken all the stuff out. I don't need to know your blood type, or what do they always say in medical shows, cross type and reference, but none of that. It's bone. It's just, bone is bone when it gets to me. Anybody can have it. That's a good question though. Because it does sound like, well, where's it, I'm out of my tibia, what's it, no, just right nearby. So that's a sinus lift, very commonly done. Need some skills to do it. Solutions. So we're going to get into 2 solutions. First for the partially edentulous and now for the fully edentulous. Exactly how does this work? Partially edentulous, 1 tooth, for example. Here's the really basic setup. This is how implants got started, and this is probably 90% of the implants I do. Missing a tooth. We place the implant in. Maybe there was a bone graft. Maybe there wasn't. Maybe we put the implant in at the same time of extraction. That is, if there was sufficient bone for primary stability and no infection present. Put the implant in. Wait for the osteoblast, the bone building cells, to creep around that sponge and grab a hold of it and keep it solid. Go back later and uncover it, because we tend to cover these with your gums almost all the time. Sometimes we leave it open. Usually it's covered. Open it up. Place an abutment inside of there, make an impression, send to my lab, get back a crown, and the crown cements or screws over the whole process. The community went from everything being screwed down to everything being cemented, and the pendulum is swinging back towards screwing down. A problem arose that nobody saw coming, and that was when you cement this, it's usually below the gum line a little ways, and unless the dentist or his assistant, who is usually assigned the task, is exceptionally good at getting the cement out, a little cement might stay behind. And if you don't have Olympic-style oral habits, you may not get the cement out either, and 5 to 10 years later, your implant is failing. One of the biggest causes of delayed or latent implant failure today is leftover cement from the cementing process. So the powers that be have said, hey, think about screwing the whole thing down. So in that case, this and this are all one piece. There's a hole in the top of that and a screw that comes out the bottom of this. The whole thing is simply set into place, and then a lag screw goes through the whole business and just lags it down. You fill in the hole on top with a little composite resin, the filling material. So it's easy. One way or the other. I do both. It depends on where I am in the mouth, how much gums are left. It's usually a decision I make at the time of the impression. You don't need to know that decision when you start the process. It's when you get to the impression date. Where's the gum line in relation to my implant? What's going to happen with that? So pretty straightforward. And again, the parts, an implant or tooth root or surgical post, people call it whatever they want, but it's an implant. Anything at all that screws into that implant is called an abutment, which confuses new dentists an awful lot. Because there's a healing abutment, an impression abutment, a final abutment. I mean, I've got, I don't know, probably 3 or 4 more. There's abutments, anything that screws in there. So you got to identify which abutment is. And then, and then the crown finally. That's for one tooth. What if we do a few teeth? You've got a bunch of natural teeth there, and you're missing some in the back. You've got to get rid of that one-sided partial denture that flops around your mouth and has hooks and wires. We put in 2 implants, screw down a couple of abutments into it, and then put a bridge right over those. It's fine. What about the flexibility I talked about in the other, when you put a bridge over natural teeth? Same problem. You can actually flex that enough to where one side pops up, leaks a little bit, and comes out. Does it happen? Yep. And we put it back on. There's no decay, there's no fracture. Sometimes it pops up and comes loose. The other thing is this. Once upon a time, 90s, this business here, see, there's a screw. If you look close, there's no screw in the top of this yet. That little post or abutment is going to go down in, and then a screw like that little one there is going to go through it. That screw can loosen, like all screws. They loosen more under vibration. Screws loosen under vibration the most. Well, when you bite, you're creating a little microscopic vibration in your teeth. And so screw loosening was a real issue. The protocol, therefore, was to put this permanent bridge or permanent crown onto that abutment with a relatively weak cement. I've got 5 levels of cement from weakest to strongest. We were putting these in with like number 2. Pretty weak on the scale. Why? Because if the screw loosened inside everything, I could use a tool and pop that crown off, tighten the screw back up, and put the crown back on. If I used one of my stronger cements, the only way to get that crown off is going to be to cut it off and destroy it and have to make a new crown. Well, dentistry, the researchers, actually the guys from Alabama in that 2-year program that Carl Misch founded, went and visited NASA. Because what did NASA have a problem with when space shuttles went up in the air? A lot of vibration and stuff rattled loose. They had, apparently, astronauts have written books that screws would appear out of nowhere. Stuff rattled loose. So NASA fixed the problem by redesigning threads. The threads that connect, not the threads out here, the threads on the inside that connect the abutment to the inside of the implant. I don't know the mechanics of that or the physics, but I know they corrected it. You almost don't see any screws loosening anymore. Key word in that sentence was almost. So occasionally you'll still get a thread loosening, and therefore we still always cement with a relatively weaker cement right here. So after a few times of flexing that, can it come off? Yes. Does it happen very often? No. When it does, is it a problem? No. We just cement it back on. So pretty straightforward. I have that conversation with every single implant patient I see, because otherwise they'll be the one that comes in with their tooth. You didn't tell me it could come out. It can come out. Not the end of the world. Fully edentulous. All right, so that was partially, if you have just a few missing teeth, that's it. Fully edentulous. Here's what the media has going on today, right? This is the, what's the name of the thing? Clear choice. We've all seen the commercials by now probably. Teeth in a day is the other way that people describe it. And here's why I'm lecturing on this today, because I have so many patients asking me about it. One of my first ever full-on edentulous cases came to me, I don't know, it was a couple months ago. How come you didn't do it in a day? Like, heck, it wasn't around, this wasn't around then, number one, and even today, it's not in a day. But it's good marketing. It makes people ask questions. All right, fully edentulous. There's 3 categories of fully edentulous restorations. That is, what are we going to put on the implants and how's it going to be affected? We dentists categorize those 3 things as how it is stabilized in the mouth and how it is stabilized from coming out of the mouth. So what's it resting on and what's keeping it from falling out? Tissue supported means it's resting on the gums. There's no implants involved. Tissue retained means your gums are keeping it from coming out. There's no implants involved. That's a denture. But that's how we describe it. Tissue supported implant retained is where the denture still sits on your gums all around, but there's some implants involved that keep it from just falling out. Also very good. And then there's implant supported, implant retained, and this is where it's setting on the implants or a structure attached to implants, and those same devices are keeping it from coming out. Think of it as snaps. And again, this is the crux of my talk today. Under the implant supported, implant retained, there's 2 subcategories of removable and fixed. Show you examples of all of it and why. And there's choices, there's good reasons to choose. All right, first one, tissue supported, tissue retained is a denture. A full denture like my grandparents had since their 40s. Bone goes away, things dissolve, you can't eat, they come out at night, 17% of people don't wear them to eat, that whole thing. That's a denture. Tissue supported, implant retained. This is where your denture still looks like a denture and it still sits in your gums all the way around, but there's a couple of little keepers in here, a couple of snaps. And I have some on the table. I really encourage you to come up and look after we've done. You'll be able to play with it more. This is where some snaps help to keep it from falling out or retain it. So it's tissue supported, implant retained. That's a good example of just 2 implants. And what happens there? 2 in the front, if this was my arch, 2 implants in the front, it still kind of bobs up and down in the back a little bit. But keeping it in from falling out is a huge step forward for people who have very shallow gums, very shallow bone down there, and they find themselves sneezing their dentures out or not able to speak. Or there's some great videos. I didn't put them in this time because by now everybody's seen them. Grandmother who's skydiving, everybody seen that one? And she screams, woo, her dentures fall out, gone. Maybe I should put it in, everybody's seen it. There's a bunch of videos of people losing their dentures in weird places. In a wedding, like in Pakistan or something, some foreign country, it's at church, Catholic church it looks like. They're at the altar. The priest hands her the chalice to take a sip of wine. She does. She looks like she glugs it a little bit, not just sip, and passes it to her husband. And he goes, puts her teeth back in. They were in the wine. He takes a sip himself and then moves on. But it was recorded. Great video. I'll put them in for next time. So tissue supported, implant retained, it's an improvement to where we were. Here's the retainers. There's other kinds. I'll show you in a minute. This is called a locator attachment. This is a cutaway. That's not what they look like. This is what they look like. There's a metal bar, a metal receiver that's attached to the implant. It is an abutment because it's screwed into the implant. So that's a locator abutment. Over the abutment is a little plastic, or actually nylon, to be specific, pressed nylon keeper that snaps into these little grooves, and then a metal housing that keeps it from expanding too much. So there's a blue and a red. I've got 5 different ones of those, all with different levels of retention. They go from 1 pound to 5 pounds of retention. If I put 2 of those in your mouth at 5 pounds each, it takes you 10 pounds of pressure to lift it off. That's the equivalent of 2 bags of flour. If you can hold 2 bags of flour with your thumbs, that's a lot of weight. Most people don't let me put the 5-pounders in. I usually start with 3s and say, do you want more or less? We usually stay with 3s. I have some people with really bad arthritis, 1-pounders. That's it. And they generate 2 pounds and we're done. This is newer compared to what was out there. This is the locator I just described. Here's a cutaway of what's called an O-ball attachment. This is where what was screwed into the implant, and that's a mini implant, we don't use them anymore. What was screwed in was what looked like the back of a truck hitch. So your trailer hitch in the back of your truck comes up with a little knob on the end or a ball. An O-ring is on the inside, has been cut away of that housing. The problem with those was the O-rings wore out too fast. These nylon keepers don't wear out so quick. They still wear out, easy to replace, relatively cheap, 30, 40 bucks. But that has to stick up taller. And when you've got to fit all this business inside a denture, you're doing everything you can to control the height. Height is a big problem for us, and it was in the early days. So now we got everything lower to the gums. It's much easier to manipulate. So that's tissue supported, implant retained with 2 keepers. What if those keepers are poorly placed? That looks like what I just described, right? 2 keepers in there. Problem is, somebody who doesn't know what they're doing put them in, and you now have a denture that goes from here all the way to here and back. And those teeth right here, when you go to put pressure on them, what's happening? They teeter-totter forward. Those implants are right in the middle of the arch, so that whole denture teeter-totters forward, impossible to wear. What's he going to do? He'll end up placing a 3rd implant here because the patient will complain enough. Where do those belong? Right up there in the front. This way it can still flex a little bit in the back and nobody seems to mind. As long as they don't fall out, we're good. I'd say most. 80% of the people that have 2 are fine with 2. Some come back for more. Another example of poorly placed implants. Here's just a couple of missing teeth. This dentist really didn't control the gums very well. This is good gum tissue. That's good gum tissue. This is lip tissue on the inside of the lip. It doesn't belong there. He should have done a gum graft first. He should have built up the bone first. And if this person smiles higher than this, they'll be embarrassed. I'd be willing to bet that this person doesn't smile very high, so everybody elected just to leave it alone. None of the pictures in here today are my pictures, by the way. I know Osher Center, Christopher Wren, is very big on not self-promoting, so I don't. So I can show you mine if you want sometime. They're really good. More implants, is that a question? So I have 2 up in the front. All right, what if I put 2 more in? Good, a little more stable, like it, a little more expensive. That's why the range goes from 20 up to about 35,000. How about 2 more? Get 6 in there, great. And now we can start to cut the palate out of an upper denture. So anybody wearing a denture that's got a full palatal coverage, which they all do if it's a regular denture, you don't taste your food as good, you don't talk as well, you don't feel the roof of your mouth, you don't manipulate your food well. So if we can cut the roof of the denture out, it just fits better. I've done a bunch of those over the years. Those are really nice. They snap in, they snap out, everybody's happy. It still sits on your gums. This is still tissue supported, implant retained, full edentulosum. Where do we stop? How many implants do you want to put in? 6, 8, whatever. It depends on the bone. The bone in the mandible is very dense. We categorize bone as D1 through 4, category D1, D2, D3, D4. D1 is density, very, very dense down here. D4, up here in the back of the maxillary arch. If you want to put it in terms of wood, because that's how we learned it, this is going to be like maple. 2 is going to be up here. You're going to be getting into pine. No, pine's not here. Sorry, like oak maybe. And then pine down here, and then balsa or styrofoam up here sometimes. It's really weak. So in those cases, we have to densify the bone. We have tools that, instead of drilling bone out to put an implant in, denses it up. So again, just different ways to do with it. So how many implants do I put in? Depends on where they're going to be. Do I need to replace a few teeth up here? 2 implants down here probably do it. A few teeth up here, 3 or maybe 4 implants. So at surgeon's discretion. And a lot of that is based on something called Hounsfield's units. If we take a CT scan of your mouth, which we do, then we can look at the density of the bone in a specific measurement called a Hounsfield units. Get that number and you know how many implants you're going to need based on your experience. So where do we stop? We don't, we just keep going. Implant supported, implant retained. Now, the denture is no longer sitting on your gums, it's sitting on the implant. All your biting force is being delivered to the implant. I need more implants. So where do we stop? When we have more implants. Here's a great example, and I'll blow it up a little bit here. This is a very typical restoration these days. It's called a locator bar, or a milled locator bar. The bar, and that's the same one right here, is sitting on top of 6 implants. 1, 2, 3, 4, 5, hard to see the last one, 6. It's where the holes are. 1, 2, 3, 4, 5, 6. Because screws are going to go down through that and keep it squeezed into the gums. On top of that, we've placed some locators. I don't need 6 locators. I need 4 for balancing out with a nice squared off bar, because the inside of this is also going to be squared off to go around it. Even without the locator attachments, and there are sometimes we'll do that, especially during that like teeth in a day thing, we'll put the bar in and not load anything. No retention from it, no clips, no snaps. Even like that, these stay in pretty darn well. Just that kind of like 2 plastic cups stuck together. There's nothing keeping them together but pure friction. It's hard to get those red Solo cups apart sometimes, right? Same idea, just frictional static compression. So we'll do that for a little while things heal and then go back and load them later. But that works really well. And as a removable solution goes, that's really state of the art. And that's really darn good. They don't come out until you take them out. I can change how much pressure comes off. If I put 4 of my 5-pounders on that, I've got 20 pounds of force to take your teeth out. Most people can't get that out. They're hanging on. They get their husband and come help me. So we tend not to do that, but it's available. We can. And every 2 or 3 years, those start to get weaker and we just replace the plastic housing. It's not expensive. Here's a slightly different stuff. Here's the locator, milled locator attachment bar I just described, helping to keep things in. This is a hater clip bar. It's a little bit different. The thing I like about it is it's lower to the gum. So if I have a process here where I can't afford that much room inside my denture, because the patient just doesn't need that big of a denture, I can go back to a little bit older style. I was doing these till about 10 years ago. A hater clip. That is a horseshoe-shaped clip that sits over a roundish bar, kind of like my hand being too small at the outset. It has to expand to get out and go over. So it kind of clips down in wherever those yellow things are. Yellow things actually lock up inside your denture. So the yellow things are not on the bar unless the denture's in place. This is just a cutaway, for example. That works very well as well. So we have options is the idea. Lots of options on how to do it, and we can handle the space. What about fixed? This is what everybody wants to know about. This is implant supported, implant retained, fixed option. This is the coup de grace. This is the $35,000 case per arch. And that is simply where little screws go through the prosthesis into the implants that are in the mouth. 1, 2, 3, 4, 5, 6. 6 on top is about my minimum. 5 on the bottom is about my minimum. And it depends on density, quality of the bone, angle of placement, where exactly. My max is usually 6 on the bottom and 8 on top, but I've done more in some weird cases. But 6 on top, 5 on the bottom is a real good number for anchoring things down, fixed and not going anywhere. So that's where we are with the teeth in a day. When they say teeth in a day, what they mean is you're getting some temporary teeth the same day of surgery. Before the surgical date, you'll have had 3 or 4, sometimes 5 appointments to do all the measuring, the mapping of everything out. We're doing a CT scan and an intraoral 3-dimensional scan of your mouth. There's trial fittings of things that go over the teeth that are there just to help mount top to bottom to make sure that we know where your hinge is in relation to how your jawbone works down there. A lot of stuff happens behind the scenes. The day of surgery, it is teeth in a day. All the teeth come out. We place a bunch of implants in. There's a whole lot of bone work that goes on that day, flattening out, adding to, subtracting from, whatever. And then some sort of prosthesis is going to go in. Usually, teeth that you don't take out. They're going to be plastic or acrylic, to be specific. They're going to be the acrylic temporary teeth called PMMAs, polymethylacrylic acid, PMMA. Those go in, we sew the gums, and here's your instructions. For the next 2 months, do not chew into anything stiffer than you can cut with the side of a plastic fork. That's pretty limiting, but there's a lot of food. You can eat all the fish you want, all the pasta you want, breakfast foods for dinner. Any of that, that kind of mashed potatoes, fine, whatever. You don't have to go on a liquid diet, but if you can't cut it in half with the side of a cheap little plastic fork, you have no business eating it for the next 2 months. With that caveat, teeth in a day. Are they your final teeth? No, because a lot of healing is going to go on now. We just did a lot of work, taking teeth out, adjusting bone, putting implants in, making all this stuff. The final bar isn't even fabricated yet, if that's the kind of thing you're going to get. So you end up going out, healing, waiting. It's, again, 4 to 6 months is typical. Come back, and now we start the final impression process. Usually another 4 visits for that to happen until you're all the way done, trial fittings and all that. So it's teeth in a day. It's just not your permanent teeth today. And I wish they would make a better distinction on it, but the closest office of Clear Choice I think that we have near us is up in Northern Virginia. I happen to know somebody who used to work there, and she left. She was a prosthodontist. She left because she said it just felt like a mill. It was just get them in, get them out, get them in, get them out. So it works for the right environment, but can we do that? Yes, I do that in my office. I never say you're getting teeth in a day or whatever. I let them know. You'll get some temporaries the same day of surgery. That's a more appropriate statement. All right. Choosing fixed options. What about it? So the bar retained clips, it fills in the void where the bone was lost under the lip. Does that make sense at all? If you have a bar underneath this denture, then you still have a denture that fits over it. An example of that is sitting up here. You won't see so well from where you are, but that has a bar on it. This is still looking like a regular denture. When it goes up in there, it still fills out your lip. Why? Because sometimes we need to. This poor guy on his left-hand side, he's been missing teeth for a long time. If I gave him screwed in plate, the fixed option, it is not going to fill out his gums in the front, his lips in the front. He needs a removable option that has some sort of support under the lip. Let me go back. I might have lost some people on that a little bit. Because when this goes in, you can see there is no flange. There's no extra gummy part that goes out into here. We can't. Because if we screw that in and there's a big lip flange that goes in the lips, you can't clean it. You can rinse all you want. It's never going to be clean. You've got to make it oral hygiene cleansable, oral hygiene friendly. So when this goes in, it actually sits about a 0.5 millimeter above the gums. It does not push on the gums, which means your toothbrush can wiggle right up in there and get it all clean. But that means there's no additional lip support up under the lips. There's some tooth support down by the lip itself, but not up under the lips. And that's a real problem for someone like this guy who's lost all that support. He really is a great candidate, and I'm sure he did, get a implant-supported removable denture, and that was appropriate for him. When I say removable, though, they stay in. They just stay in. Then you take them out at night, but it's like, it rides over and around the ridge. It's best for teeth that were lost years ago with the resulting bone loss. The fixed, on the other hand, screwed in, does not add to the lip dimension at all. It just supports the teeth. So here it is on the bottom. And like I said, a little gap, that's probably more like 1 millimeter, but we try to shallow that out a little bit, 0.5 millimeter. And that's riding on some implants. You can't see them all. And you can clean into that, and that's screwed in, but it offers no support. When do we use these? When you've recently lost the teeth and the bone is still relatively full. You haven't gone through bone atrophy yet. And in most lower arch cases. For whatever reason, you don't need as much support down here because your chin does the job. So this is way more of an impact effect on the top than it is the bottom. And I think I put a slide in showing the difference. There you go. So if it's fixed, you see that is solid all the way through, and it goes on and it has this little gap between the two. If it's removable, all that flange sticks out over and under the lip up and through here. How do you decide? Take a look at yourself in a profile shot. Your dentist will help you decide too. But that's the secret to deciding between the two. And if you really, really, really have to have fixed, screwed in, and you don't have the support, then we'll build you the bone. I can go back in there, do all kinds of grafting there, bone grafting, tissue grafting. We can add to that bone. It just adds to a cost sometimes unnecessarily. If you don't need the bone to support the implants, only to support your face, you could forego that cost and just have something removable that helps to support your face. Totally up to the patient, adds to the cost. What about clear choice? This is right off their website, I think. Teeth in a bad way, teeth all better. That's what I was going to talk about here. Sorry, I've already discussed it. So not teeth in a day, teeth in a year is the better way to look at it. But you leave that day with some teeth. She left that day with some teeth. This is not the same day. She's not even wearing the same outfit. If it was truly teeth in a day, they'd show you all their patients with the same outfit every time, wouldn't you? Look at their website. None of those people are in the same outfit. It's after healing and conversion and all that. It is possible to do teeth in a day, but not every case qualifies. What if you having the teeth out and I need to put implants in, there's an infection there. I already said you can't put an implant in the same day if we have active infection. Even after I put you on antibiotics for weeks, sometimes there's still infection present. Stops the process. What if the bone quality is not there? Teeth that come out and some unexpected bone releases with it. I don't have enough bone to anchor my implants. I don't have my 10 newtons per centimeter of force to drive that in to get primary stability. No implant there today. There are some caveats. And some days, the day of surgery is the day we find out how it's going to go. I always have a backup plain, old, original looking denture there. Because worst case scenario is I close everything up when the teeth come out, do some bone grafting so it's ready for next time, and then put in a regular overdenture and say, that's how it went. This is going to be years for the next few months until we get back to implants. And there's no way around that. And that's not me, that's science. Is it possible? Yes, but it violates decades of best practices methods, what I just described right there. Support, good initial fixation, no infection present, proper amount of support, being able to load all the implants equally. It goes against that unless everything's working. I can't speed up bone healing much, but I can a little bit. If we take a sample of blood out of your arm, spin it down in my centrifuge and collect something called the PRF, similar to PRP, you've all had plasma-rich, you've talked about platelet-rich plasma, PRP. It's a double ARP even already. You inject that in the knees and shoulders and elbows, makes things feel better. PRF is like that, platelet-rich fibrin, not platelet-rich plasma. We harvest that out of your blood, collect it, and inject that in with any bone particles that we're putting in, either yours or somebody else's, doesn't matter. That actually speeds up healing about 2 months. So when I used to say 6 months, I often say 4 to 6 months, because sometimes 4 is plenty. And then we got a little tool we can go in later and measure how much bone attachment there actually is. It's called an ISQ, Implant Stability Quotient tool. You just put a little threaded knob on there and get a little magnet that's hooked to a reader next to it, and it tells me how much vibration there is, tells me whether or not the implant's ready to go. So sometimes people are like, I've got to have it in 3.5 months. All right, well, let's look at it in 3.5 months and see if I'm okay with that. And there's a limit, 70 or above. So I can speed up a little bit, not much. You just can't make biology do much more than biology is willing to do. Bone cells have to grow and they have to attach. It increases the failure rate during healing. Again, we're loading these with dentures right on top of freshly placed implants. I told you that was a no-no because it's going to break the connections to those implants and the bone ends up not healing around it and they get wobbly. Well, if you put one post in the sand, you can walk over and push it over. Put a foot in the sand, push it over the finger. If you put 8 posts in the sand on an arc, and that's important, and you nail them all together, try to push one post over. Not so much. Less movement. Same thing here. If I put 8 implants in all at once on an arc and I link them together with some sort of framework, the amount of disturbance that you'll do to it if you're only eating things softer than what you can cut with the side of a fork, plastic fork, it tends to minimize the impact on those implants. So it does work. Does it increase the failures of certain implants? Yes. Often it's okay. If I put 8 implants in and I lose one in the middle, can I get by on 7? If there's 7 good strong ones, yeah. Even 6, yeah. 5, not so much. The fewer is not great. But you can afford to lose 1 or 2 sometimes if they're not like both on the same side. So these teeth in a day, it works. We can do it. I tend to discourage that and tend to go a more traditional route. But I do it frequently enough. I know it works. I can get it done. The teeth you're leaving with are just temporaries, like I said. If anybody ever says the words all on 4 to you, run away. There's a real big push to make this more affordable for patients by decreasing the number of implants. Can you put a full, locked, loaded, screw-supported fixed denture on 4 implants and have it stay? Yes. Can you put it on 3? No, never. So if you lose one at any point in the game, your goose is cooked. And you've got to go back to square one, put some more implants, redesign everything. In my circle of friends, we have a saying, all on 4, none on 3. Some of the leading institutes are teaching all on 4 as a viable way to go because technically, as long as you get 4 good ones, you're good to go. I like a little backup. I still carry a spare tire in my car. If you're the kind of person who doesn't believe in spare tires, then all on 4 might appeal to you. I just thought of that. That's a good analogy. There's even people who are placing implants all the way to the zygoma. They're all on 4 because there's not enough bone in some places. Goes from the mouth all the way to the underside of their cheekbone. The zygoma is this bone right here. You're underneath your eyeball. That is a 3-inch implant, and it passes right through the middle of your sinus, in the air in your sinus. Very well-known institutes are teaching it. It's possible, but the number of failures is outrageous. 50% of those are failing. If you're in the good 50, you're fine. Otherwise, no. Even with all those limitations, it can still be a good choice. This teeth in a day business. That can still be a good choice for some people. With the right dentist or the right team, your dentist may not do everything. In my office, I do. Not all of my dentists that work with me do. None of them do sinus lifts or bone grafts like that. None of them will do teeth in a day. I'll right away that same day. So even in my own office, not everybody does that. Often it is a dentist with an oral surgeon or a periodontist placing, and they're going back and forth. That does mean a lot more trips, but it gets the job done. No matter the method, no one needs to go without some sort of teeth while things are healing. Some sort of provisional removable teeth are going to be involved. It may be locked onto the implants. It may have to come and go. You will never have to leave an office with no teeth. So there's always teeth in a day. It's just not the teeth you're thinking of. It's not the final teeth, right? What could possibly go wrong? Sounds so good. Implants are almost infallible, right? Well, here's an example of, it's hard to see. I wish I'd blown that up more. The bone is actually very nicely intact here, and it's starting to shy away on this side right here. There's a little micro gap forming. That's where gum tissue is creeping down along it. The one thing an implant can't take is to adhere by the gum tissue. It just doesn't work. The implant starts to get mobile. It feels like a kid's tooth when they're loose and about to fall out because it's loose and about to fall out. So that it can fail to integrate. And that's usually in the first couple of months. And you know it because it doesn't feel right. The dentist has you come in, there's usually a little blister above it from infection process going on. There's signs, and those are the ones. And what we do, we take it out, clean it up, put you on antibox foil, bring it back in a couple months, put an implant in. And again, in most offices, might include, that's a no-charge visit. It's luck of the draw, and we stand behind our work. You can get peri-implantitis. You've all heard of periodontitis. There's peri-implantitis. Substitute teeth for implant, you have peri-implantitis. If you don't take good care of them, you're not brushing, flossing, these are not impervious. They are more impervious than teeth, but they're not impervious to problems. So here's the thing. Right next to the implant should be a nice level collar of bone with the gums around it. If you're not brushing and flossing and taking good care of them, that bone starts to sink down and down and down and down and down, and you end up with big red inflamed gums all around it, and you have peri-implantitis. It's treatable. Same as periodontitis is treatable. We can treat it. It's not ideal, but it's doable. Involves lasers more than anything else these days. Another thing wrong, poor angle of placement. Here's a surgeon without much training. That implant's almost fine, although you should have a little more room between these two to get it straight out. You can't restore that without bumping into this. He's going to have a custom fabricated abutment that comes in here. He's probably have to drill some of that tooth off to get to it. He'll finish the case. It'll be terrible. It'll probably fail. Angles on implants are usually a sign of future failure. It's just physics. If you have an implant with a screw that goes directly to it, the force of nature that you put on with your teeth is right down along the long axis of the implant. That's good. They weren't made to be having force put on them this way because things snap. That's usually when breaks happen. Gum tissue loss. Again, here's somebody that probably should have done a gum graft first to build up. They end up losing gums, so that's another thing that can go wrong. A fracture of the actual implant. I've seen 3 implants fracture in my career. None of them, thankfully, were my implants, but I've had to retrieve 3 implants that were broken like this. And that means trephining around that implant. Anybody know what a trephine burr is? If you're going to make a door knob hole in a door, you don't have a great big drill. You have a drill that has what looks like a donut attached to the end of it, and the saw blades around the edge, and you drill that core out. Well, I have a trephine that goes 15 millimeters up, looks like I'm drilling a doorknob hole out and just trephining around the whole thing. That's no fun for anybody. It's a stressful day because a lot of things go wrong trephining an implant out. But they can break. It's all right. The actual prosthesis itself can break. If you've got, say, 4 implants with 4 of those little simple locator attachments, no bar, just a denture that sits up on there with 4 snaps, the whole denture itself can break. And that's acrylic, again, traditional denture material. So, no problem, then we'll put a bar between them, and the bar will keep it from breaking, until the stuff fractures off the bar. So is it perfect? Nothing is. This is nature and physics and products in the mouth, and you can generate 1,000 PSI if you're a grinder clencher. It's better than no teeth by far. The odds are way in your favor on this versus having no teeth. But things can happen. People need to understand there are still some limitations, some ramifications. All of that can be repaired. That can be repaired. That can be repaired. The thing that has come about more recently in the last 5-6 years now is that these teeth, if they're attached to a bar, not all by themselves, attached to a bar like this, we can make them out of something called zirconium. You've all heard it because of the old fake diamonds, cubic zirconia. Chemically similar, just as hard, rock diamond hard. Those things are so durable. The lab that invented the thing, Glidewell Labs, has a video. If you Google Bruxier hammer test or denture hammer test, they have a sledgehammer on a hinge, like a 5-pound sledge. They put a pair of dentures underneath it on a wooden block. They lift the hammer up and they let that 5-pound sledge go. Smacks down into it, no damage. You do that to a regular denture, it shatters a million pieces. They do the same thing with crowns. We can make single crowns out of zirconium now too. And we do. Most of our crowns are zirconia crowns now. Anyway, that is becoming a thing of the past because of improvement in materials. It's not, people ask, well, is it so rough it's going to wear down the other teeth if you have natural teeth? No, surprisingly, the wear surface of it is extremely shiny. So it doesn't wear the opposing arch. It's one of the least wearing things we have on the market now. What else could go wrong? Poor design. So here's somebody that put 4 implants up front but extended the teeth, another 2 teeth in each direction back. If this guy chews nuts back here, he's putting so much pressure on these guys that something's going to fail. If you wear that and you only eat a soft diet, and some people truly do, they've been eating a soft diet all their years because they're denture, I just don't want it to fall out. I don't want to start eating good and plenties. I just want to eat my boiled chicken a little more comfortably. Then that'll probably last. But if you put any pressure back there, the whole thing is going to start to fail, because it's not being supported. Physics cannot be cheated. That's the plain and simple of it. Anybody that knows math and physics, you cannot beat physics. What else? Oh, front tooth implant. So I love this slide. What can possibly go wrong? Here's a dentist. This is off of his website for how good his work is, before and after. Well, if you don't mind your tooth being too long, too wide, the wrong shape and the wrong color, then yeah, good job. It goes back to what I said earlier. You need a dentist who's been doing a few of these, or at least knows. I had a patient, it was my first implant. I still remember his name, Roy. I won't tell you his last name. He's deceased now. I was up front with Roy. Roy, this is going to be my first implant. Are you okay with that? He goes, do you know what you're doing? I said, I believe I do. He goes, all right, I'm with you then. So we did it. And then my second and third implants were on my own employees. They had no choice. So 20 years ago, you got to start somewhere. So I'm not saying never let a junior dentist do it, but make sure he knows his stuff. Maybe make sure there's a senior dentist watching over it, because that's not a final result anybody's proud of, except for this guy, wherever he is. Conclusions. I told you I'd finish a little early. Here's my conclusions. Dental implants have revolutionized the replacement of missing teeth. There's no question. That is just Nothing has ever come this close to it. I don't know how we're going to get any further along other than stem cells. They are growing teeth out of stem cells now that can be implanted into a person. Pretty nifty. Only in the research stage. And I don't even know they're doing people yet. They might still be working on sheep or pigs. It's coming. How well they can direct the traffic in terms of which tooth they're producing. I'd hate to end up with a molar up here or an incisor back there. I mean, I imagine they're working on that. Otherwise, there wouldn't be such a hoopla about it. But so that's going to be right now, without doubt, the best we have. And there's choices how to utilize them. When Brandemark did his first studies, the only thing that was cleared by the FDA was 5 implants down here and a denture to fit on it. Done. It's all for the first 5 years. That's all you can do with implants. Now we have all these different things to hook into it. So much more available. The skills of the clinician are paramount. That's a conclusion. You've got to have someone who knows what they're doing. Plain and simple. Patient habits cannot be ignored. If you're a clincher and grinder, I need to treat you with more implants. Sometimes a lot more implants. If you're a little old granny like my grandmother and 3 implants worked, 3 implants. The only reason that she got 3 implants and not 4 was because it's all I could squeeze in what little bone she had left, and I couldn't do any more because she was on bisphosphonates, so I could not grow more bone. I even took a risk putting 3 in where she had a little bit. It was in her chin is what it was. So it was enough to stabilize the front. And she ate as soft a diet as she ever had. Just more of it. There are still potential complications, as I just laid out there a minute ago, and we can't rush biology and we can't cheat physics. We maybe can tweak it a little. And we're doing that now with PRF and all that stuff. But at the end of the day, there's some healing. There's always going to be some healing time with implants before you're done. And R&D simply means improvements are still being made. And maybe my recent statement of you can't hurry biology will be null and void in a couple more years. I don't know. But right now, that's where we are. That's it. Thank you very much. I will take questions. Go ahead.
The tissue supported retained with the implant, is that also like a $6,000 piece thing?
No, good question. So the implant fee, I hate to actually quote fees, especially being taped, but I will give you a range if that helps. So the implant body itself is going to be usually between $2,000 and $3,000 to put in per implant. Then you're going to have a fee for the abutment that goes above it between $500 and $1,000, depending on what's being used, who's doing it, what lab it's coming from. And the denture itself will usually be another $2,000 or $3,000 on top of that. So that's where you get into about 20 grand for those. So you might have, what, 4...
Even with the tissue supported and just using the
just
as a retained.
Just 2. So if you just got 2 up here, you might be into that for like, what's my math on that? 5, 6, 7, under 10,000. Under 10,000 for 2 implants and a denture. Yeah, probably shy of 10,000 somewhere.
Because
all in.
The older we get, we have to figure out how long am I going to keep chewing.
Right. Here's an interesting thing, and I'll share this story with you. I've shared it many times in other things. I have people come in and they go, well, I'm 75. How much money am I really going to put into my mouth? All right, well, maybe ask your kids, because they're the ones that are going to worry about it more than you, right? When you go, there's no U-Haul behind your hearse. So when you go, you're not going to care how much you spent when you were there, right? But here's my story. Patient came in. It has nothing to do with implants. It just is in the second year of my practice, and it affected me for the last 30 years, or 28 years. I've been in practice for 30 years now. David and Peggy came in to see me. I can say that now because I'm sure they're both long deceased, or they moved back to New Jersey last I heard, and that was a dozen years ago. Peggy and David came in to see me. David comes in dragging his oxygen. That's how my story starts, right? He's got the little container and the oxygen tube hooked up. David's days on this earth are numbered. If you're dragging your oxygen, you've got a shelf life. He's missing some teeth in the back, and he's got a bunch of decay back there. And the right treatment for him is 4 bridges back there. This is 28 years ago. Implants are not even part of my vocabulary then. So 4 bridges back there. He said, work up what you got to do to fix me. I said, okay, fine. Where'd you move from? Off from New Jersey. What'd you do as a restaurateur? Okay, whatever. Here's my business card. It was a wooden nickel, big one, because the name of his restaurant was the Wooden Nickel. All right. So hands me his business card. Thanks. So we work it up. He comes back in to talk about it. And I said, well, here's the deal. It's going to be whatever it was, thousands of dollars. And I said, I got to approach the elephant in the room. Do you really want to put that kind of money into your mouth when you're dragging your oxygen and you don't sound so good to start with? He goes, Sonny, you let me worry about where my money goes. He goes, can you fix it or can't you? I said, yeah, absolutely. He goes, all right, let's get going. So we did. Took a couple months, did the whole thing, done. 6 months later, David passed away. Now, I feel a little bad about that. They spent a lot of money. To me, in my early years, that was a lot of money, especially. I'm sure to them it wasn't no sneeze either. So Peggy comes in a while later. I went to the funeral and all that, and Peggy comes in, and I said, Peggy, I sat down, I said, I feel so bad. I said, I let you guys spend so much money. And David didn't even enjoy his teeth for 6 months. She goes, oh, you stop right there. She was as brash as he was. And I said, well, what? She goes, you know what Dave did for a living? I said, it's a restaurant, right? She goes, no, from the time he was 14, he was in a restaurant. It's all he ever knew was food. Food was his life. He opened restaurants and sold and closed and opened more because he just couldn't fill everybody's palate with enough food to make him happy. He was so into his food. And when this started breaking down, he couldn't enjoy food. And then with the whatever he had going on with his lungs and all that, I think, whatever he had. So she said it was about the only thing that gave him pleasure the last 6 months of his life was being able to eat whatever he wanted again. You let him die a happy man. All right, so lesson learned. I will never judge somebody's wallet or needs. So when you say, we're getting older, got to figure out how much longer I'm going to spend, I don't get involved in that conversation ever because I don't know. My grandmother, when she retired at 65, promised us all she'd be dead at 76 because that's long enough. That's what she said. Those were her words. I'll be dead at 76 because that's long enough. And she died at 96, relatively healthy, except for the last 2 weeks of her life. I mean, who knows? We don't have crystal balls. So that's my point to everybody is if you want better teeth, just work out the money and do it. You won't miss it. Your kids will. Tell them to earn their own living. Take a little lesson from Warren Buffett. Yes?
My wife is worried about the antibiotic that's used right after the tooth is pulled. Begins with a C. I don't know.
Clindamycin.
Yeah, clindamycin.
Right. Cliacin has an effect on some people to cause some intestinal problems. Most people are okay with it. If you get raging diarrhea while taking it, you are supposed to stop that right away and call me. And I'll say, let me know if it's still that way tomorrow. And it always goes away. So, but it can cause some real intestinal problems. But if she's allergic to amoxicillin and azithromycin, then that's the third drug of choice. Amoxicillin and penicillin is the number one choice. That's what we give 90% of the people, unless you're allergic to it. And if they've had a problem with that before, we get to the expensive stuff like Avalox. That's $600 a dose. I mean, a bottle. That's a lot, but it works, and it doesn't give people diarrhea. Question? I said, yep.
What determines whether you do a crown or an implant? Is it because the tooth
What determines whether I do a crown or an implant? If the tooth is salvageable by itself, by just putting a crown on it, you put a crown on it. Because there's no better root system than what God put there. If I cannot save that tooth, it's cracked down the middle, it's got an abscess that won't resolve, it's broken off to the side, it's a variety of things that just can't save it, it's broke below the gum line. If it has to come out, then the second best root down there is a titanium one. Yep. Questions? More? Nothing? Well, thank you for having me. The models are up here. I encourage you to come up and look, and I'll stick around. We can talk about those if you want to put them in your hands and ask questions. Happy to do it. Otherwise, thank you very much for having me.
Thank you.
Good. Thanks.